just go here. Okay, now I'm very excited to introduce half of our incredible benign heme nurse navigator team. On behalf of Tammy Gates and Angelica Galera, we have Angelica presenting today.
So today, today I'm going to be talking about the long and winding referral, how a process or a referral gets processed in our clinic. I am, like Dr. Chi said, one half of the navigators in our clinic. The other is Tammy, who's in the back there. And we have no disclosures. Our objective for this piece of the presentation is to describe the workflow of a hematology referral and to also recognize the important parts to include in a referral for us to make it an easier process to get the patient scheduled. And this matters because over the last 2 to 3 years, we've seen a really high increase in referral volumes and also in patient volumes in our clinic. We have about 3 full-time hematologists in our clinic, and some our hematologists have clinic once a week or every other week. And we just want to teach, or more so just show what kind of things to include in the referrals that get sent to us to decrease the delays and improve referral qualities for our patients. The poor referral process can lead to a lot of delays with our patients. We see about 15 to 20 new patients referrals per day, so about 100 per week, and about 40 to 45 new patient slots available a week, depending on provider availability. And here is our basic process that we follow. A referral gets placed, it gets reviewed by the intake nursing team, it gets triaged. If everything's good to go, appointment is scheduled, and we see the patient in the clinic. When we get referrals, we get them from within UC Health, so PCP offices, specialty clinics, inpatient teams across all specialties. The ER, our external referrals usually come from primary care offices and other hematology clinics for second opinions. When we review the referrals that come in, the first thing that us nurses look at is the urgency of the referral. We have a work queue that holds all of our referrals, and we will look through the priorities. We get ASAP, urgents, and routines, and we kind of work it that way. We look at the diagnosis. Any kind of notes that come from the referring providers are super helpful for off the bat triaging for us. And we look at, is the information provided adequate? Is it a hematology diagnosis? What kind of records do we have? In Epic, what kind of records we get from external providers? And usually for our MPNs, if they have any outside pathology, do we need an internal review for those? A part of our triage process is our goal is to get urgent referrals in within 1 to 2 weeks. Right now, we are scheduling about beginning of October to mid-October. And it's been really hard to get patients in. And so we keep our own wait list that we manage for our clinic. Open slots are checked throughout the day, sometimes several times within the hour. And when we have all of our information, we make sure that it goes to the correct hematologist because not all of our hematologists see for the same things. One of our biggest barriers to scheduling is that we can't get a hold of a patient either for scheduling or to get more records. Our protocol is to call a patient 3 times before we close out the referral. We often don't get recent records to review from external providers. We run into a lot of insurance issues. If a patient doesn't have insurance, we do offer HDC, which is UC Health's hospital discounted care. And we are not able to schedule those patients until they've begun this process. And this page, it just kind of shows how many detours we take while reviewing the referrals. This call center box here at the bottom, our call center can schedule patients with or without a referral, with or without records. And so when this happens, we track all of our call center referrals. We have to go back and review everything all over again, make sure that we have enough information. If there's not enough information, we will have our administrative support call the patients to see where we can get additional records. Then we go back and request these records, and there's a wait time of sometimes like 2 weeks to about a month to receive records, which pushes back and delays patients getting scheduled in our clinic. Once we do receive those records, then we go back and review and triage it all over again. So we oftentimes we go in circles a lot. For us, we consider a strong referral a hematology diagnosis. Sometimes we'll get referrals where the main diagnosis listed would be for hypertension. But then you read through the visit notes and there is a small piece that says refer to hematology for anemia. And it's a lot of just trying to figure out what's really needed. We do not see for oncology diagnoses or solid tumor kind of stuff. That's a separate division here. We look for pertinent history. Again, any kind of comments in the notes sections does help a lot with initial review. We require or at least prefer to have at least 2 sets of abnormal labs for our abnormal count referrals. And we like to see a trend over the last around 5 to 7 years is what we try to get for our providers. Any kind of prior workup available, pathology reports for our MPNs, any kind of imaging for blood clots, mostly just whatever kind of things we can get our hands on. It helps the providers a lot with their consultation. This here is what we would consider a poor example of a referral. This is one we got recently for a patient who was being referred for unexplained normocytic anemia, low haptoglobin with a normal iron and normal retic. When I went in and reviewed this referral, he had labs drawn on 2/16 of this year, and this referral was put in on 2/13. So labs were checked after the visit, and it came back normal. I believe the haptoglobin was also normal, but the last set of labs this patient had was from 8/19/2025. And so to me, it seems like they referred based on a set of labs that was taken almost a year ago now. An example of a strong referral, this one was one that I just kind of made up. It's for IDA. And in the comments, I wrote iron deficiency anemia times 3 years, colonoscopy done 4/10/2026, no bleeding found, on PO iron for 6 months, no improvement in CBC or iron panel or ferritin levels. Please consult for IV iron consideration and workup for anemia. So it tells us what we need. It tells us some basics about the patient. Another good thing to include would probably be a recent CBC. Again, just for like off the bat triaging and urgency. We don't really require that it be this specific, but any kind of information that would be pertinent to what the patient would be seeing for, it helps the nurse navigators a lot. And just to review, what we're looking for is the urgency level, referral questions. Does the patient have a PCP who can manage their care in the interim or recheck labs for us? Because we are scheduling out so far. Does the patient already have a hematologist? If so, do they really need to be seen by a second hematologist? Is it something that their current hematologist can continue to manage? what additional outside records are needed, what kind of pathology review is needed. Again, our goal is just for the patient to come in with as much information for our provider so that their visit is productive and informative. Common bottlenecks that we see is there's not enough information in the referral. We are often sent solitary CBCs with one abnormal, and we like to see that at least at 2 or at least a trend from 5 to 7 years. A lot of our external referrals, they don't send us any labs or visit notes with the referral. So that's when we would have to go back, request these records, wait again for the records to come in. And that just continues with the delay of getting patients in. The clinical question is unclear. We're not given a proper hematology diagnosis, and also insurance issues. If a patient is being referred from outside of UC Health, it is helpful to know if their insurance is within network. It's not a requirement again, but it is very helpful. How to help your friendly nurse navigators. Just make sure that the referral diagnosis matches the labs. A lot of what we see is, for example, they list polycythemia, but their labs are all anemic. Send any kind of relevant clinical information at the time of the referral. With our external referrals, again, we will receive that one set of labs. And when we try to request more, they tell us that we need an ROI or authorization to get more information or more records. And the ROI is very hard to get from patients. We will send out additional inquiries to referring providers. Sometimes we don't get any responses back, which again delays the referral getting processed. More information, more information, more information. If you can't tell, we need more information. And updated labs is possible, if possible, because if we're scheduling out 5 months, then by the time the patient is seen by the provider, they wouldn't have had labs drawn for about 5 to 6 months, sometimes even longer. And to inform your patient that you are referring them to hematology and why, because we'll call patients and they'll ask us, why are we being referred? We've never talked about this with our referring provider. This was no mention of this. And so they'll refuse to schedule, or they'll come into the appointment not knowing anything going on. And here is our hematology clinic info. If you need to either call our clinic or if you want to send some referrals to us. I think that was all.
Thank you very much, Angelica.